Before I start my talk, just want to say 2 or 3 things. First, I want to thank Antonio for his excellent introduction, because most of the key points that I'm going to talk about in my speech were introduced in his talk. So that was very useful. And the second thing I want to say is I want to start by apologizing, because I'm going to mention a lot of you in my presentation through publication, stuff like that. If inadvertently I forgot somebody, please don't be offended. This is not on purpose. Okay, so improving bone remodeling, stimuli based on strain energy density. Basically, I'm going to focus on the same sort of argument, which is mechanics is all well, but it's not quite enough if we want to have some predictive tool that can be applied into the medical application. So, what we try to do in Strasbourg, we have connections with hospital, dental faculty, etc. And the medics guy, they come to see us, they ask us a very simple question, and basically they wait for an answer in about 3 months' time, which obviously is not possible. Okay, so they want predictions for medical applications, and the first thing we need to do is to try to understand what is the question. I believe that most of you know, when you talk to, when you're mechanicians, physicists, whatever, when you talk to medical people, the first thing you need to understand is that they don't have the same language as you, and you need to understand what they want. Okay, you need then to identify the node locks, experimental, numerical applications, and then eventually develop the right tool, not for you, but for them. And what you do is ask yourself the question, how to address the question from the mechanical, physical, biological description, and then you need to build a comprehensive system that we talked about a little bit in the previous presentation. Okay, here you have a femur head, you have seen also this picture, and as mechanicians and physicists we have a very sort of pragmatic approach to the problem, so that we build some very geometrical sort of system in order to try to solve some medical applications. Eventually we go to the local scale, look at what happens in the biology and the microfluidics, etc. And then we try to build some tools that will try to change as a function of time, predict the evolution of things as a function of time, so that eventually we can propose this solution to the medical people, say, in such and such conditions, the structure or the problem will change in this way. So what I have done in this presentation, I agree with you, this is completely arbitrary, okay, and it's from my point of view, but anyway, it gives a fairly good idea of what happens. What I have done, I have looked at all the people here, okay, and tried to see what everybody is doing, what work they are doing, what publications they do, and I have classified these works by the sort of standard things that everybody is doing. We have some people working mostly on theoretical problems, building some sophisticated theories and models, okay. We have some people coupling theory, numerical and experimental, and then we have also couplings between theory and numerical models, and we have some other people doing experimental, dealing with experimental problems like biology, cells, etc. Now, the thing is, from these works, as you have seen in the previous presentations, from the physical sort of mechanical point of view, it's very difficult to look at the local scale and what happens locally in order to build a microscopic predictive tool. Okay, so what I've done, and we have focused on that lately in Strasbourg in the last few years, thanks to the works of Tomek, Francesco, etc. This is a classical model that I have presented before, so you know it already. I'm not going to present it too much. We have a mechanical equilibrium, okay? Still talking about the structure approach to the bone problem, okay? We have a mechanical equilibrium that's based on strain energy, and then we calculate a sort of what we call mechanobiological stimulus that is based on the strain energy density. And from this stimulus we have bone density evolution, okay, which can be bone or eventually biomaterial if it's integrated, and this bone density will change as a function of the stimulus, which can be either positive or negative. By the way, I want to come back to a point that has been presented before, which I think is interesting. From a mechanical point of view, if you build a model on strain energy density, knowing that strain energy is positive, okay, strain energy increases, bone density increases. Simple. I'm going to present you a case just out where we will focus on the tooth, orthodontic problems, okay? And when you deal with orthodontic problems, when you apply a force on the tooth, which is sideways, okay, then you have compression on one side, tension on the other side. The tooth moves and the bone remodels, okay, but you still have strain energy positive, but you have negative side on one side and positive side on the other side. How does that work? So that means the mechanics, the strain energy mechanics is maybe not completely adequate in this way. So, from this model, we have developed 3D models which are completely macroscopic. We have integrated these equations into some, firstly, COMSOL multiphysics, then we recoded it into a finite element model, and then we looked at the evolution as a function of time, but it remains completely macroscopic. So we have no insight of what happens really inside the bone. So the question was, then, going down the scale, what happens? So we discretized this problem and tried to look at how reasonable the microscopic model is and how do we integrate the microstructure into the overall structure of the bone. So we build a very simple geometric problem, as you can see here, just a square representing a hole within trabecula, and then we identify the trabecula, and then we run, here you apply shear stresses on the bottom and the top square, okay, and if this model and say the active side of the problem is just on the board of the trabecula. Eventually you have bone growth on the internal side, and then we build a very simple geometry with microstructure. Probably you have seen that in the literature. This is very commonly. Here you have the initial problem with boundary conditions, applied loading condition, and you see the stimulus density rate and bone density as a function of time. This remains completely mechanical. Something that we have started to work on lately from the previous question asked is, what is the influence of the bone microstructure? The difficulty in that is, if we assume that strain energy density is a good model, it means that for a given geometry you always find the same answer, because it's completely macroscopic. However, if you want to build patient-dependent problem, immediately you see that strain energy density is not good enough information. Okay, so that means locally there is something happening that is not taken into account into the strain energy. I agree that even if you have homogenized statistic distribution, okay, macroscopically speaking, from the mechanical point of view, you find the same answer. True. But if you have a different biology from the patient, one with osteoporosis, for example, the other one not. Even if you have the same microstructure, over the long time, does not give you the same kinetics. So surely, here, there is a question that is not answered. So we have started to look at that lately. We have built some microstructure finite element model, and we are currently looking at what is the influence of the distribution of microstructure on the bone kinetics evolution. Now, you remember I've showed you the publications before from people here in the room, and I classify them by sort of theory, numerical, experimental, etc. I have taken these things again, but organized them in a different way. And organize them by some fields of application, theory models, living biology, microstructure, modeling integration, multiphysics, we talked about before, multiscale and stochastic. But eventually, what we want to do is this. This is the dream, okay? And this is the reality. We cannot do that. The question that was asked before is, are we able to calculate in a finite element model a whole bone at the molecular size? Of course, this is not possible. Okay, so how do we do that? Do we look at small scales, do some sophisticated model of the small scale, or do we do macroscopic model where we need to have some optimization, homogenization, whatever you want to call it? And when you go from this local scale where you have the information to the global scale, you lose something. The question is, are you ready to lose in order to have a good predictive model? Okay, so we looked at that previously. I'm not going to go through all the details, but we agree that work started Julius Wolff, almost, okay, and he wrote this equation where you have a drift rate function, which is function of strain, biological coefficient, and the drift rate limit, which gives a sort of topological optimization as a function of some given shape boundary conditions that you have defined. Can be bone, can be anything, doesn't really matter. And then from this work followed some other works from Wisks, where the bone density, Rho, becomes a function of stresses and Young's modulus, function of remodeling coefficient matrix multiplied by some strain. And then we have the works of where the bone density is a function of loading cycles, and then we have here again the strain energy, and Beaupré again with stimulus calculation, and so on. Okay, I think most of you know all these works, so I'm not going to detail all that. And as time goes by, models become more complicated and more complicated and more complicated. But as the work becomes complicated, the question remains, what do we do with all that? Because it's still mechanical, so we lack still the information in order to build this good predictive model. Okay. In the last 2 years, we started collaboration with Untitled Chapter in Strasbourg, whose people were interested in knowing what would be the bone remodeling as a function of time for patients. So patient comes, there has a tooth all over the place, okay, and then we put forces on the teeth. We want to realign all that in a good manner, so we want to be able to predict what will be the bone remodeling as a function of time. And immediately you see that if you just put the mechanics, it does not work. So the modeling needs to take account mechanical load. We have been interested in cell recruitment and migration and also vascularization and oxygen import, because when you actually move the tooth, you have a ligament between the tooth and the bone. Okay, when you compress the ligament, you have blood flow change inside the vascularization that is inside the ligament. This blood flow change leads to oxygen change. Oxygen change leads to cell differentiation or cell numbering change, which ultimately leads to bone remodeling. So the collaboration that we have done both with l'M3 laboratory in Metz, a geometrical model. By the way, this is a true patient model, okay? And we did the implementation of the model. This is kind of trivial from mechanical point of view. And with the help of Hervé Petit and Sidum here, we did some imaging. We did some imaging of the ligament that is around the tooth. This is a horizontal cut. You have the tooth here in the center. Here you have the ligament on the surrounding, and this is bone on the external part. This is a cut through the ligament, okay? And we have built this model. This is the question I was asking before. So you apply horizontal force, you have the ligament here, and eventually you have bone resorption on the one side, and you have bone reconstruction on the other side, which ultimately leads to translation of the tooth. We apply orthodontic forces. You have either ligament compression or tension. You do the mechanics. This is easy. And eventually, through the ligament compression or tension, you have O2 decrease or increase, which leads to a variation of oxygen concentration. Leads also to osteoblast or osteoclast multiplication. We integrated also the cell migration and recruitment inside this ligament, and coupling all that leads through the bone model I showed you before to some biomechanical stimulus calculation and bone resorption and reconstruction. This is currently ongoing work. And the stimulus I told you before is going to be updated soon. I'm not going to present it to you today. So, just to show you quickly how do we do that, we have found in the literature some cell concentration as a function of oxygen content, okay, and we fit the and osteoclasts, and we used some diffusion equation for the cell recruitment and migration in order to be able to predict the bone density evolution. This is just preliminary results, okay? The objective is, once the model is fully implemented, to actually integrate it into the real geometry that I showed you before. This is just a simple case that I'm going to show you here. So we have a simple geometry. Here is the tooth, here you have the ligament, and on the external side you have the bone. On the figure at the top you will see the strains through the geometry. Here you will see the cell activity here inside the ligament. On the right side you have the oxygen content, and you will see the bone density evolution function of time in the center. Hopefully it works, okay? So we see that, so of course it's a rough model for the time being, but we see that we are able to model the bone density evolution. And as the question I asked you before is, what is the link between the local information and the macroscopic predictive tool? Here we have decided arbitrarily that the important factors were cell number, oxygen content, strain, migration, recruitment, etc. So we have selected ourselves as a small number of parameters which we think in this case are important, and we homogenize that over the whole geometry. Of course, it's not a good model, and it has some fitting parameters. I can always present that to the medic. It will work, and eventually, if I tune the parameters in the right way, I will be able to represent the evolution, the patient evolution, 7 times of his medical treatment. Okay? If I use this model for another patient, where the conditions will be different, not knowing this patient, of course, the result I will get will be the wrong result, because the tuning the parameters will not be adequate. Okay? Right. Okay, so then what? Coming back to the figures I've showed you before, this is the way we look at the problem. This is the kind of thing that we do now. But the simulation can depend on various factors, which are mechanical, nutriments for cells, for example, for bone piezoelectricity, cell migration, or even epigenetic factors. We know that bone growth. Okay? How far does it grow? 10 centimeters, 15 centimeters, 20 centimeters? When does the bone know it should stop at that point? We don't know that. So it requires experimental identification and modeling at different scales, but it also requires integrated theory for biology. What does that mean? Some people started to work on the coupling between biology and mechanics. Biology is discontinuous by nature. A cell is not continuous into the macroscopic model. There is no continuum biology theory, there is no thermodynamic biology. If I look on the right side, and I have cells, yeah, with fibroblasts, also some osteoclasts, but in the model I've showed you before, it's a continuous model. How many cells do I have? How are they distributed? How do they impact on the kinetic evolution? I need to construct this biological theory. I don't have it. So, almost finished. I have shown this before, some of you know about it. For solving the problems, we have numerical difficulties, we have parameter identifications. We need the tools to identify these parameters, and we need to couple experience, numerical, and application. For all these boxes, we have a number of questions to answer. Most of them, we don't know the answers. And not only that, we surely don't know how to couple. That was known, but this is mostly mechanical. Now I'm going to add an extra layer. We have done that, or sort of, we have all at least asked the question about the mechanical problem. How do we add the other points? The piezoelectricity, cell nutriments, cell migration, epigenetic factors, and most problematic is the biology that we start to think about, okay, which is an important factor for the evolution. Can be bone, can be any other biological material, okay? And the two main difficulties, from my point of view, are here. How do we build this continuum biology? Because we cannot calculate the bone evolution, macroscopically speaking, without accounting for the homogenization of the biology. And how do we account for the bone growth, say over 10 years period, during the childhood period, okay, and knows that it will stop at that point without fixing the external boundary conditions. We don't know how to do that. Okay. Thank you very much. Everything was clear. Yes?
Which way cells are into...
No. Easy. Yeah. Yes. This one? So, we have a cell density, evolution as a function of time, D is a diffusion tensor, which depends on the strain and the principal direction. Yeah, exactly. So as soon as you strain in some specific direction, this loaded direction will lead the migration of cell in that direction. If you differentiate them, that means you have to differentiate the parameters and the diffusion.
And osteocytes are not?
No. Yeah.
Do you have any connection with the kinetic model developed by Komarova, I think in the past, that was used in some paper by approach?
Yeah, the straight answer is no. The explanation is that we basically try to build the model as a function of the question that is asked. And for this specific case, the answer was we want to know what is the positions, what are the position of the teeth after 1 week, after 2 weeks, after 3 weeks for given patients. So we had to think about what do we know, what boundary conditions we know to answer that question, and that was the way we actually built the answer. This is the difficult question. You have a scan at the beginning. If you're lucky, you have a scan at the end. Usually you don't. And in the middle, you have no scan. You just have images. So you can have 3D images from internal small cameras and stuff like that, but then you have to reconstruct the position of all the teeth as a function of every patient treatment dates. That's all you have. You have no, from a patient point of view, the patient comes, he has his standard treatment. If you want extra information, you need some specific medical sort of procedures, and we don't have that.
So if you have, say, 2 time points at the beginning and at the end?
We have more. We can have up to about four points over a period of about 6 weeks. Yeah, no, we have 1 scan at the beginning, maybe we have 1 at the end, but it's not sure. The other ones are just images, 3D images. When I say scan, I mean you use CT scan. From the images, you have only the outside. The tooth is supposed to be rigid, so no deformation, and the ligament is supposed to have constant thickness.
But you want to know the reconstruction?
Yeah.
So
We have it at the beginning. Yeah. Yes. Yes.
What degree of complexity or model, what kind of model you might take if you model constraint that you will only get
Yes. Yes, correct. The true question is what is the bone density distribution in the volume in terms of microstructure, the evolution in time, and we don't really know that. Because I didn't show it here, but actually when you look at the scan through the thickness, okay, the density distribution in terms of microstructure is very, very heterogeneous. So you have to make an approximation into the model for different zones of bone density and see how it changes as a function of time. This is the hard point. Okay, thank you.